May I go ahead?
Please go ahead. Yeah.
A 5-year-old boy with ADHD is being evaluated for treatment options. His parents are concerned about starting medication and inquire about non-pharmacological interventions. Which of the following non-pharmacological interventions is not appropriate
It's
for
most.
management,
It's most appropriate.
is most appropriate for managing his symptoms?
Mm-hmm.
A. Cognitive behavioral therapy,
Mm-hmm.
CBT, dietary restrictions. B. C. Elimination of all sugar from his diet. D. Parent training in behavior management.
Good.
Answer D. Parent training in behavior management.
Okay. So doctor is going for D. Does someone have a different answer? Looks like a lot of people are going for D. What is the Facebook team saying? Are you also going for D or are you going for something different? Is it cognitive behavioral therapy, dietary restrictions, elimination of sugar from the diet, or parent? So the answer is, so those on Facebook who answered A, the answer rather is D. For young children with ADHD, parent training in behavior management is an effective non-pharmacological intervention. Okay, it helps parents learn strategies to manage the child's behavior, improve compliance, and enhance parent-child interactions. While dietary interventions may benefit a small subset of children, they are not universally effective. So if you have a child with ADHD, one of the best ways to help the child non-pharmacologically is through parent training. Okay. Because at times the parents can get frustrated, right? Okay. Next question. Who read for us, please? Okay.
A 7-year-old boy is brought to the clinic by his parents due to concerns about his behavior and academic performance at school. The parents report that the child is easily distracted, fidgets constantly and frequently, interrupts others during conversations. His teacher has also noted that he has difficulty staying seated during class and often leaves his seat without permission. His parents are concerned about how these behaviors are affecting his relationships with peers and his academic progress. The boy was diagnosed with ADHD, predominantly hyperactive impulsive presentation, 3 months ago and has been on age-appropriate dose of methylphenidate. Despite medication, the symptoms persist with no significant improvement, and the boy's appetite has decreased significantly.
Mm-hmm.
Which of the following is the most appropriate next step in the management of this patient? A. To increase the dose of methylphenidate. B. Switch to an extended release formulation of methylphenidate. C. Add behavioral therapy to the current treatment regimen. D. Switch to atomoxetine. E. Refer to a child psychiatrist for evaluation of comorbid conditions.
Beautiful. What would be your answer? There's a child on age-appropriate methylphenidate. Appetite has reduced. Symptoms are worsening. What will you do, basically?
I would probably switch because he's having those effects from the methylphenidate side
Beautiful.
effects.
Beautiful.
And so I'll switch to atomoxetine, which
Beautiful. But the answer is switch to atomoxetine. Why? Can somebody help me? Why will you not switch to an extended release formulation of methylphenidate, or why will you not increase the dose of methylphenidate? Can someone tell me why these two answers are wrong?
Because of
Because he's
the side
already
effects of the
Beautiful.
medications. And so when there are
Beautiful.
side effects, we stop
Beautiful.
and switch to another line of drugs.
Beautiful. 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 Now I have a question. Methylphenidate and atomoxetine, which of them is a stimulant? Which of them is considered a stimulant?
Methylphenidate.
methylphenidate.
So, yeah, and then refer to a child psychiatrist for evaluation of comorbid. We've not gotten there yet, right? A child is on methylphenidate, is having side effects to it. Because of that, symptoms are not well controlled, and therefore that is why we are switching to atomoxetine. I think with this particular question, I missed my explanation somewhere. Okay, need someone to read this case for us, please.
A 10-year-old girl diagnosed with ADHD combined presentation has been on treatment with a stimulant medication, amphetamine salts, for the past year. While her attention span and hyperactivity have improved significantly, her parents have noticed that she has become increasingly irritable, especially in the afternoons and when she returns from school. Additionally, the school reports that she's having frequent mood swings and seem more emotional than usual. The dose of her medication was recently increased due to a plateau in symptom improvement, which is the most appropriate next step in managing this patient's symptoms. A, increase the dose of amphetamine salts further. Switch to a non-stimulant medication such as guanfacine. C, add a short-acting stimulant dose in the afternoon. Assess for the presence of comorbid mood disorders. And E, recommend a drug holiday on weekends.
Okay.
So,
what's the answer? Doctors, please type your answers.
Okay, she additionally, the school reports that she's having frequent mood swings and seem more emotional than usual. The dose of her medication was really increased due to a plateau in symptom improvement. So I want to assess for the presence of other comorbid mood disorders in this patient.
Does someone have a different answer? And that is the truth. Assess for the presence of comorbid mood disorders. Dr. Idris, the way you are picking your answers nowadays is interesting. What has changed? What has changed with your approach? I really want to know. What has changed with your approach?
Thank you, doctor, for the opportunity once
What
again.
has
I
changed?
think what has really changed is the amount of information that I have from the MedCognito group, right? So yes, so and I think at this level of my training for the exams, I think I'm better oriented in terms of the quality of information I have from the portal, right? And also interacting with other members of the team, right? We get to should I use the word rattle over these stuffs when we meet at least twice a week, outside meeting with you 2 times a week as well. So I think there's better information, and most of all these informations here are also in the portal. So by the time you go through them, you get firsthand information about them. And the beauty of it all is that I'm not under pressure to begin to read so many things, right? So it's like I have a focused reading, I have the plan, I have all the information there for me to go after. So I think that's basically what has improved.
Good.
Yes.
Good. Next question. So doctors, you can see it. Next question, please.
Can I read it again?
Yeah, please read. Yeah.
A 12-year-old boy with ADHD, predominantly inattentive presentation, has been on atomoxetine for 6 months. His teachers report a significant improvement in his ability to focus on tasks, and he is completing his homework more consistently. However, his mother reports that he has been complaining of frequent headaches and stomach aches, especially in the morning. The side effects, his academic performance has improved, and he has not shown any signs of hyperactivity or impulsivity. What is the most appropriate next step in managing this patient? A, discontinue atomoxetine immediately and switch to a stimulant medication. B, reduce the dose of atomoxetine and monitor symptoms. C, add an over-the-counter pain reliever for headache management. D, encourage the patient to take atomoxetine with food. E, refer to a gastroenterologist for further evaluation.
What's your answer?
I think I would first want to reduce the dose. It doesn't side effect from atomoxetine.
Anyone with a different answer? So you are going for
B.
B. Let me see. So it looks like a lot of doctors are also going for B anyway. So you are going for B. It looks like a lot of doctors are going for B. What does the marking scheme say? Rather, the answer is to encourage the child to take the atomoxetine with food. Now, let's see why B is wrong. Reducing the dose could decrease the effectiveness of the medication in managing the ADHD symptoms, right? And addressing the side effects first is a more balanced approach. So why is D correct? Why is D correct? Encourage the patient to take atomoxetine with food. Atomoxetine can cause GIT side effects such as stomach aches and headaches. Taking the medication with food can help reduce these side effects, making it a reasonable first step. Because don't forget that you're trying to balance the issue of the side effects with the issue of the effectivity of the medication, right? So that is what you want to watch out for. So, because it looks like the child has gone through a lot to get to that particular dose, and the child is doing well at that particular dose of that atomoxetine. Now, maybe reducing the dose can improve the side effects, but then it can make the symptoms worse. And one thing you can do with atomoxetine is that you can serve it with food. And when you serve it with food, the regular GI side effects reduces. So that is the interesting part about it.
Dr. Brony, please, can we see this question again? Thank you.
That's the question. 12-year-old boy with ADHD, predominantly inattentive presentation, has been on atomoxetine for 6 months. Just reports significant improvement in his ability to focus on tasks, and is completing his homework more consistently. So it looks like he's doing well.
Okay.
All right. However, his mother reports.
Yeah.
However, his mother reports that he has been complaining of frequent headaches and stomach aches, especially in the mornings, despite these side effects. Academic performances. So it looks like one part is doing very well, and he has some side effects. So what do you do? So the learning point here is that to reduce the GIT complications of atomoxetine, serve it with food. That's it. Okay. Yeah. Next question. 9-year-old boy with ADHD combined presentation has been receiving behavioral therapy for the past year with modest improvements in his symptoms. His parents have now decided to start pharmacotherapy due to ongoing difficulties in school and home. A baseline cardiovascular examination, including an ECG, was performed and showed no abnormalities. However, the boy has a history of tics that began when he was 7 years old, but have been well controlled for the past year. Parents are concerned about the potential side effects of stimulant medications, particularly the possibility of worsening tics. Which of the following is the most appropriate choice for initial pharmacotherapy in this patient? A, immediate release methylphenidate. B, atomoxetine. C, lisdexamfetamine. D, guanfacine. And then E, long-acting methylphenidate. What's your answer? Parents are concerned about side effects of, or they are concerned that atomoxetine may, affect. They are concerned that methylphenidate may affect the child's history because of the past history of tick behavior. So what will you do? Were you going to do the immediate release methylphenidate, atomoxetine, lisdexamfetamine, guanfacine, or long-acting methylphenidate? The answer is to give atomoxetine. And why is it so? It's a non-stimulant medication and does not carry the same risks of exacerbating tics as stimulant medications do. Okay, it's an appropriate first-line choice for children with ADHD who have a history of tics. So 2 things or 3 things we've learned about atomoxetine today. Methylphenidate is always our first-line medication. However, if you have a child who has had side effects to methylphenidate, a child with tics, a child who has concerns with stomach ache when they are taking methylphenidate and atomoxetine, make sure that you serve that atomoxetine with food. If the child has a history of tic behavior, don't give methylphenidate, rather give atomoxetine. Okay.
Dr. Bernie,
Yes, please.
please, what about the other non-stimulants like the guanfacine? That was in
So
the question.
those are considered like almost third line to fourth line. The next best medication after methylphenidate is atomoxetine in the order in which they come.
Okay, thank you.
Yeah. So, okay, let's review your question. Why guanfacine is an alpha adrenergic agonist that can be used to manage tics and ADHD symptoms, but generally considered second line agent compared to atomoxetine. No. So your first line is always methylphenidate, like the stimulants. Then you can go to atomoxetine. The child has like an issue with side effects to methylphenidate, issue with tics, those things, you go to atomoxetine. If that doesn't help, then you can consider these other ones.
Hi,
Next
Dr. Bernie.
question. Yes,
Please,
please.
can I ask a question? Please, when is it appropriate to take drug holidays?
Oh, when a child has had controlled symptoms and has been on it for quite a number of time, at times for years, you can give them a drug holiday. Like we use the concept of drug holidays even in things like bisphosphonates as well. If you've given the bisphosphonates for about 5 years in a patient with osteoporosis, and you've done your bone mineral density, and there's been a gain in the bone mineral density, and the patient is doing well, you can give them like a 1-year drug holiday. So that's the concept of drug holidays. If the person has remained stable for quite some time on that particular medication, which the patient has to take for a prolonged period of time, you can give them a drug holiday.
Okay, thank you so much.
Welcome. So let's review this question.
A 6-year-old girl with ADHD, predominantly hyperactive. A 6-year-old girl with ADHD, predominantly the hyperactive, impulsive presentation, has been on methylphenidate for 3 months. Her parents report a significant reduction in her hyperactivity, but they were concerned about her poor appetite and noticeable weight loss since starting the medication. Her teacher has also noticed that she's more irritable in the late afternoon. A follow-up visit shows that her weight is in the 5th percentile of her age, down from the 25th percentile 3 months ago. What is the most appropriate next step in managing this patient's treatment? A, discontinue methylphenidate and switch to atomoxetine. B, maintain the current dose of methylphenidate and monitor her weight. C, administer methylphenidate after meals to reduce appetite suppression. D, consider a drug holiday to assess change in appetite and weight. E, switch to a long-acting formulation of methylphenidate.
What's our answer?
She has weight loss since starting the medication. I want to go with either C or A.
What's your final answer?
Doctor. Okay, I'll go with C.
Administer methylphenidate after meals to reduce appetite suppression. Does someone have so this child is in the 5th percentile. You're going to go with C. Yeah. So, Dr. Idris, so the way you're choosing your answers is really helping, right? Administer methylphenidate after meals can help mitigate the side effects of appetite suppression, which is a common issue with stimulant medication. So, 2 things here. Atomoxetine can cause stomach upset. You serve it with food. If you have a child who is on ADHD medication, stimulants, and the appetite is not doing very well, you want to rather give food before you give them methylphenidate. Okay. Why is A incorrect? Discontinuing methylphenidate may not be necessary if appetite suppression can be managed by adjusting the timing. So what are our take-home points here? I need someone to talk to me about methylphenidate and atomoxetine. And I think if you get this right, we don't even need to go through the rest of the lecture. because these questions are really helping us to hone it in. Can somebody help me? What are your learning points? Methylphenidate, atomoxetine, ADHD. I'm sure you came and said, oh, if it's ADHD, I know about ADHD, we are good to go. But today we are learning some key things. What are your key take-home points? Methylphenidate and atomoxetine. Who can help me?
There you go, Dr. Bruni.
Please go. Yeah.
Yeah, so we learned that methylphenidate is actually the first line drug to use for ADHD. And then it is advised to be used with food in patients who present with headaches and stomach aches after use. Also, in patients who present with weight loss, it is advised that the methylphenidate is used after food to reduce the appetite suppression side effects. And then
Before that, what about patients with tics?
Yeah, also for patients with tics, you don't use methylphenidate, you use atomoxetine for the patient with tics. Also, now atomoxetine is the choice of drug to use if a patient has predominant side effects to methylphenidate, which is the first line drug. Atomoxetine is preferred if a patient has tics or if a patient presents with like worsening side effect of methylphenidate. And then guanfacine is now the second line of choice of drug.
After what?
After atomoxetine.
Beautiful. 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 So now you realize that you have the tools to be able to break down concepts. And that is why I prefer that when you take a particular subject, you solve as many questions as possible, looking at various aspects, right? Because yeah, methylphenidate can affect, appetite, can affect weight and all those things. And that's what a lot of candidates know. What if you are presented with a different clinical scenario? And that is why I want us to look at it from all angles. When are you going to switch? When are you going to reduce the dose? When are you going to serve the medication after the person has eaten? When are you going to serve a medication with food? It is when you've done all this that you know that, okay, your review of ADHD has been comprehensive. Okay. Yeah. Next question. Next question, please. Doctors, who is helping me? Next question.
Okay, I read. A 15-year-old adolescent with ADHD, predominantly inattentive presentation, is being managed with a combination of behavioral therapy and stimulant medication. Over the past year, his academic performance has improved, but he has started showing signs of increased anxiety, especially during exam periods. He reports feeling constantly worried and has difficulty sleeping at night. A stimulant dose was recently increased due to a plateau in the improvement of his attention span. There is no history of substance abuse or use or abuse. What is the appropriate management approach for this child? A. Continue the current stimulant dose and add an anxiolytic medication. B. Reduce the stimulant dose and assess for improvement in anxiety symptoms. C. Switch from a stimulant to atomoxetine to address both ADHD and anxiety. D. Refer the patient for cognitive behavior therapy for anxiety management. E. Discontinue stimulant medication and manage anxiety first.
What's your answer?
So I would choose reducing the stimulants dose B.
Okay. Does someone have a different answer? It looks like people are going for B, reduce the stimulant dose and assess for improvement in anxiety symptoms. And is that right or wrong? Good. It is right. So everyone who wrote B got it right. So reduce the stimulant dose and assess for improvement in anxiety symptoms. Stimulants can sometimes exacerbate anxiety, especially at high doses. Reducing the dose may help alleviate anxiety symptoms while still managing ADHD. So, doctors, let's review our take-home points again, and then
Dr.
we'll.
Bruni,
Yes, please.
I see the A and D, why we can't give an anxiolytic in addition, or
Okay.
why
So
maybe
remember that this patient is on. So let's break it down. This patient has ADHD. What did we learn about ADHD management? Stimulants, first line, atomoxetine, second line. You can use guaifenesin and the rest if atomoxetine does not work. Stimulants, you don't use it in patients with tics. Atomoxetine may cause abdominal pain if it is taken on empty stomach. Okay? If you have a patient on a stimulant and the patient has appetite suppression, you want to serve the stimulant after the patient has eaten. Now, how do you prevent the abdominal pain complication of atomoxetine? Serve it with food. We also learned something. What did we learn in relation to being on a correct dose of a stimulant and the patient is having side effects? Do you reduce, or the patient is not growing well? What do you do? Do you reduce the dose of the stimulant? No, we said that you rather switch the time you give the stimulant to after the patient has eaten. Now, this particular patient's main issue is ADHD. This one we just solved. But with his ADHD, the patient has also developed anxiety. Now, we've learned another layer of information that stimulants at a higher dose can lead to anxiety. So it could be that anxiety itself is not a new presentation. It looks like it is as a result of the complication or the side effects of the stimulant use. So in this situation, if I can reduce the dose of the stimulant and still get the patient's behavior to still remain normal, and that decreased dose can also reduce the anxiety, that would be an awesome option. Doctors, are you following me? Because, in medicine, you want to make sure that you are using the least effective dose, the least effective hammer to still get the results you want. So if I can reduce the dose of the stimulant, still get the patient's behavior well controlled, and still reduce the issue of anxiety, I will do that. That's all that the question is asking you for. Okay. Now,
thank you.
sure. Let's deal with this next question, and then we wrap up. Okay, so you see, this is the answer for the first question. We did not have answers at the time. So that's when I was typing, that was a mistake. I think I hit enter and then it just moved it down, down, down. Okay, so let's switch to our PowerPoint and then finish our lecture on the management of ADHD. So in the management of ADHD, we've said that we've got to first start with encouraging parents to know the behavioral patterns and know how well to deal with it. We also want to even involve teachers, have measurable goals, and be collaborative, okay? Now, the non-pharmacologic management for patients with ADHD, you want to do parent treatment or parent training in behavior management, especially for preschool children. You want to do positive reinforcement. You want to do timing out if they have some behavioral issues. You want to do the token economy system. So, like they do something very, very good, then you can reward them, right? In the classroom, what can be done to help these children? Classroom modifications to help them, behavioral programs to help them, and skills training, which can support academic and social functioning in these children. So classroom modification, behavioral problems, skills training, which can help. What about monitoring gene management? Regularly, you want to monitor them. We've seen that they can develop abdominal pain. It can impact on their weight, their height, right? So children should be monitored regularly for adherence, response to treatment, and side effects. And monitoring tools include ADHD specific rating skills. So that's why I showed you the cadra, because there is also a tool which you can use to monitor, and you can just download that and let the patient or the mother of the patient or the father or the teacher fail them. Pharmacologic management, we've gone through this over and over and over again, and we've gotten to a very, very good point. Before we even came here, we learned about methylphenidate, we learned about atomoxetine, we learned about guaifenesin. So first line treatment is methylphenidate. Second line, atomoxetine. Who will I not give methylphenidate to? A patient with tics. Oh, what will I do with patients who develop abdominal pain with atomoxetine? I will serve it with food. Guaifenesin is never, ever, ever the first line. Atomoxetine is not the first line. Methylphenidate is the first line. They can present with other things like depression, psychosis. So what I want to do is to make sure that I help them. If they develop these symptoms, I can present an anxiolytic or something. However, I have to be very careful because methylphenidate can present after you've been given higher doses of methylphenidate. The patient can also present anxiety. So I have to look at the anxiety the patient is presenting well and know the context in which I'm going to give it. Doctors, whenever a child is on methylphenidate and they come to your office, you want to make sure that you are checking their weight and their height and making sure that they are doing good on the medication. Because if it reduces appetite, that can then reduce their weight. It can reduce, the way they gain height and everything.